Hi, everyone. Welcome back. I'm Dr. Samantha, the maternity mentor, and we're here for another one of my Monday night live Q&A sessions on this Memorial Day here in the United States. I'm here to answer your questions live, as well as answer any questions that you may have submitted onto the channel this week, plus get to a couple questions that we didn't get to last week due to technical difficulties. We lost our internet 3/4 of the way through. You can follow us over on Facebook, Instagram, and Twitter for additional content. We will link those into the description. Please like and subscribe to the channel. Subscribing to the channel really helps me out as a content creator. And for those of you who wait until the end of the live Q&A tonight, I will go ahead and give you a sneak peek at tomorrow's video, which reminds me to tell you to go ahead and hit the notifications button. Notifications bell will let you know when our videos have posted. So I am going to go ahead and I'm going to get started with the question that we have in the chat right now. And please feel free to put any questions that you have into the chat, and I will also be answering some of the other questions I have. So hi, Tess. Welcome back. Is placenta encapsulation or other forms for ingestion scientifically a good idea or a bad idea for hormonal and mental health postpartum? So I really love the topic of placental encapsulation. I have not done a video because it is extremely controversial for a lot of people. It's almost up there, I feel like, in the postpartum world with vaccines. And so it's very hard to address some of these. So for those of you who don't know, I work in psychiatry. So I am very much into, obviously, pharmaceutical medication. I prescribe medications all the time, specifically to women who are pregnant or postpartum and breastfeeding for their mood disorders. However, I'm also very much into homeopathic medicine. In fact, I am becoming certified in homeopathic medicine. So I very much believe in diet and vitamins and all this other stuff. So this placental encapsulation kind of falls into that homeopathic area. So right now, there is no evidence to say that ingesting your placenta, which is done through placental encapsulation, provides the health benefits that you'll see. You'll hear people say that it helps to restore your iron levels, to reduce your risk of anemia. It can help with postpartum depression. It can help with all this stuff. Really, there is no solid evidence to say that. Now, some people will cite that this was a practice that has been done for hundreds of years. And that I will acknowledge. We've been using our placentas in a variety of different ways for hundreds and hundreds of years. But when women were using their placentas back, say, 1,000 years ago, they did not have diabetes and hypertension and terrible health from a bad diet and bad exercise. Their placentas were far healthier than the modern day placenta is, just to begin with, just for the starters. Now, we have no real evidence to back this up. So a lot of people might say, well, what's the big deal? And the big deal comes from at least one story that came out from the Food and Drug Administration about placental encapsulation. And it was a couple years ago. So basically, here's what happened. There was a baby that was born, and the baby was slightly premature, like 36, 35 weeks, something like that. Not terrible, but enough that the baby did need to go to the neonatal ICU. So the neonatal intensive care unit is a place where sick babies or premature babies go to in the hospital. So this baby was admitted into the neonatal ICU, and basically 100% of babies that are admitted there get blood cultures. So this is where we draw the blood and we test it for infection. And those cultures take up to 72 hours to come back, but we really keep running them for up to 10 days. So this kid came in, very minor stuff. It was just like mild breathing stuff that, needed to resolve. And the blood cultures on admission were negative. So this baby was totally fine. The baby was doing okay. They were doing standard care. And all of a sudden around day 10, the baby started to decompensate and get more and more ill, like really badly. So they went ahead and they drew blood cultures again. And when they did the second set of blood cultures, the baby showed up positive for group beta strep sepsis. Group beta strep is a bacteria, we have a video on it, that is natural in a woman's like vaginal area and rectum. Sometimes, like, you can have it for one pregnancy and not another. It comes and goes, but it's a very natural bacteria. We swab you at the end of your pregnancy to see if you have this positive or if you have this present, because we're going to treat you with antibiotics during your labor in order to prevent the baby from getting GBS infection. If a baby gets group beta strep infection, it can cause sepsis and it can actually cause the baby to pass away. So we want to know ahead of time. And when we know a woman has GBS, we treat her with the antibiotics, and then we go ahead and we treat the baby too if we need to. Now, sometimes we don't know ahead of time if the mom has GBS and she doesn't have enough time to get antibiotics. So in the case of this baby, what happened was they were not sure of mom's GBS status, but baby came out and baby was fine via the blood culture. So we didn't really worry about it, right? Okay, so now 10 days forward, baby has a GBS infection. How is this possible? This baby has not left the hospital at all. When they started talking to the mom told them that she was ingesting her placenta pills. Okay, she had taken her placenta and she had had it encapsulated, and she was using that for postpartum depression. They then tested her breast milk and they found GBS present in her breast milk. And that's how the baby got the GBS infection. So it was from mom taking in her placenta pills, and then that infection basically translating into the breast milk. Now, this is why, until we have a better way of regulating this practice, that I don't think placenta pills should be used. I don't. There is no standardization. You know, there are some companies that are popping up, but there's no types of regulation. It's just like with milk banking. I believe in donor milk. I've seen it save babies' lives. But with donor breast milk, you can't just get it from a random person. It needs to come from a milk bank that has been certified and has safety practices in place to reduce the risk of disease transmission. I personally have heard of different healthcare providers, OBGYNs, in my personal community, like in South Florida, that will do placental encapsulation in their kitchens. That is not sanitary. How do you know if everything's sterile? And so you can also extrapolate that if these other companies don't have really standardized practices in place that are also being checked on by a government body to make sure, like, is their sterilization equipment up to date? Is it inspected? Is it secure? Like, how do you know if that's actually going to be a safe practice? And so that's why, as of right now, I don't feel like placental encapsulation is safe. Now, is it possible in the future this practice will be fleshed out into a much safer and more streamlined type of treatment? Yes. And I'm absolutely always looking at what's coming out and where it's at. But right now, no, I personally don't support it. I think there's a lot of different ways that we can get some of the stuff that these are claiming to do elsewhere. So that's my thought on that. That's a great question. So let me answer some of the questions that we got onto the chat this week, or onto the videos this week. So we always get a lot of bleeding questions. I'm going to start out with bleeding. I'm bleeding and I'm only 3 weeks pregnant. The bleeding started today and I'm worried. I'm 5 weeks and 4 days pregnant. I have brown discharge and clots, and later on the discharge is jelly-like. I did a scan and there is just a sac with no heartbeat. In this situation, can I wait for the heartbeat, or is it a miscarriage? And finally, is it normal for a 7-week pregnancy to have brown discharge with cramps? So all three of these questions that we're starting out with for bleeding, they all start in early pregnancy, the first trimester. And I think this is a really great place for us to start when it comes to bleeding. So one of the things we start out with, that early pregnancy, 3 weeks pregnant. Well, the thing is that bleeding that may be going on could be a regular menstrual period. I personally had a friend who had 3 full-term healthy babies who bled throughout her entire first trimester, like every single day. It was just something about how her body was when she was pregnant. You can bleed for a variety of different reasons. And especially in that third, fourth, fifth week when your first menstrual cycle is coming due, sometimes your body doesn't exactly know that it's pregnant. It doesn't quite realize what's going on, and you'll get some version of a period. That's why the question at the 5 weeks, which showed brown discharge, clots, and a jelly-like substance, that could be a miscarriage, of course, and that's very sad if it is. But it could also just be a regular menstrual cycle, or what your body's trying to get out from a regular menstrual cycle. Brown means old blood. It means resolving bleeding. We have a video on the colors of bleeding. And so we're not as usually concerned with brown blood as we are with like a bright red, which is active bleeding. And so sometimes in these early pregnancies, you will see a little bit of brown discharge because it's the body trying to flesh out that last bit of the menstrual cycle. Now, you can see a sac without a heartbeat. Early ultrasounds are very problematic, in my opinion. You still need to go get them done. If you're having any kind of bleeding, you need to get checked out. The standard is going to be an ultrasound. You still need it because it can derive a lot of good information. But it can be problematic because sometimes we don't see everything we need to see, and it makes it seem like something is wrong. Okay. And it's very important that you guys understand that despite all of the good technology we have, despite everything that's working in our advantage as far as ultrasound goes, it's still not perfect. It really isn't. So just make sure that you are just being mindful that you want to take a look at the big picture and not just little details. So there could still be a baby in a heartbeat, even if the sac looks empty. One of the ways we can confirm whether you're having a miscarriage or not is to go ahead and draw your HCG levels in your blood, which is the human chorionic gonadotropin level. And that's the blood hormone level. We draw your blood, and 3 days later, we draw it again. And that level should go up. And if it is going up, that means your pregnancy is probably going well. And if it is going down, that probably means a miscarriage is taking place. So those are one of the ways that we kind of check this out to see, what's happening or not. Now, could you have, we're talking about our 7-week pregnancy now, brown discharge, remember that's probably old blood, with cramps. So cramps becomes the tricky thing. We don't like to hear cramps when you are pregnant because that could be some form of period, like uterine contractions. And uterine contractions could be a sign of a miscarriage. So we don't like to hear about cramps, but they can happen sometimes. Again, it's very, very hard to determine what's normal or what's not normal for somebody. So the best thing you can do is get checked out. Get checked out, guys. It's the best way for us to figure out what's going on and for you guys to figure out what's going on. The one thing I will tell you about cramps, a lot of people get dehydrated and that causes uterine contractions. So please make sure you are drinking lots and lots of fluids. Hi, Nicole. How does BV accrue? I am assuming you are talking about bacterial vaginosis. So if you are not, please let me know what you are talking about. I haven't been pregnant in 5 years and I'm pregnant again. Congratulations. So bacterial vaginosis doesn't really accrue. So bacterial vaginosis is actually, okay, so it's caused by microorganisms that are actually normal on your skin, like on your vaginal flora. It's normal. It's just a part of what's down there. However, it can flare and cause a symptomatic infection for a couple different reasons. The most common reason is actually when the pH balance of the vagina changes. And it causes the environment to be such that the bacterial vaginosis will actually grow and it will expand and then you become symptomatic. Now, the reason why we kind of hear of it as a sexually transmitted disease is because of that change in pH. So sperm can change the pH of the vagina. So it can change it such that now the BB can grow. And so we attribute BV with men. It's not that the man necessarily caused it. It's simply that change in the flora. Okay. Now they can also have it on their skin. So it is possible they can introduce it into the area. But it's not because they picked it up from some kind of sexual contact necessarily. It's just an overgrowth of natural bacteria. Now, when you are pregnant, you are immunocompromised. This is why we walk around and we stress to women, get your vaccines, do all this stuff. Don't eat. If you guys have ever heard about don't eat like the raw fish and the unpasteurized cheeses and stuff, that's coming from immunocompromisation. That's not even a word. It's coming from the fact that you guys are immunocompromised. Our immune system would go into super hyper overdrive and actually try to create antibodies against your baby if it wasn't for the fact that naturally our immune system becomes suppressed when we're pregnant. And so because it's suppressed, we get very, very sick very easily. And so as a result, a lot of stuff can happen. No, you don't need to get your husband checked. It's very rare that he would be the sole carrier. And what happens is most likely the BB was in your vaginal area, but his sperm has made the area kind of change. Already, pregnancy hormones change bacterial flora of the vagina. Your vagina changes like crazy during the first trimester. A common cause of bleeding in the first trimester is sex. And the reason why sex is a common cause is because the vagina thins and dries out the tissue because of the hormones related to a healthy pregnancy. So that tissue can tear easier. It's the same thing for all of this stuff with the BB and other things. The flora is such that it makes it easier for this stuff to grow. I see BB all the time. You need to get it treated. That's actually the biggest thing. I'm not worried about your husband reinfecting you. It's probably going to fix itself once you get treated once because you're going to kill off all of it. But that does mean that you need an antibiotic. So if they haven't given you an antibiotic, you need to go get one as soon as you can. I get a lot of questions on antibiotics. A lot of people are very nervous to use antibiotics during their pregnancy. Here's the thing. I just told you guys, women are very immunocompromised during their pregnancy. So it's common for us to see all sorts of infections, including urinary tract infections. BV, urinary tract infections, both require an antibiotic to get treated. If it is left untreated, it can lead to a whole bunch of complications, including preterm birth, miscarriage, and stillbirth. So please, Nicole, go get it checked out and go get it treated. They should be offering you an antibiotic for it. Once you've had the antibiotic, you should be all set. The only thing you might need to worry about, we tell a lot of women, is make sure you and your husband potentially take a shower before you have sex, if you can, because it's just then you kind of wash off some of the kind of surface skin level bacteria that you might have, but you don't have to be crazy about it. If you skipped it, it wouldn't be a big deal. But like, if you can, you do, that's awesome. Okay. So I hope that helped. Please ask me if you have any other follow-up questions to that. So I had a question on bed rest. So I am currently on bed rest until full term. I just got out of the hospital because I was experiencing light vaginal spotting at 21 weeks. I found out my cervix is shortening. I didn't have a cerclage because my cervix is 2.66 centimeters and there is no funneling. Do you have any tips for my bed rest? Also, I'm anxious I didn't get a cerclage. So let's talk about this. So you are so welcome. I have an antibiotic video, Nicole. Nicole said she's a little nervous about taking antibiotics, for anybody who's wondering. I have a video on taking antibiotics. It's one of the biggest things that people get really nervous about. And let me tell you something, it's really beneficial. I might be talking about antibiotics in a little while, so stick around, but I'll let you know. So, cervix. We have a uterus, we have a cervix, okay? Your normal cervix looks kind of like this. It's long, it's thick, and it's closed, okay? This little slit perfectly represents the cervix, in my opinion. When we go in to check your cervix at first, this is exactly what we feel. It looks like just like this, right? Okay, so when your cervix dilates, it goes like this. So this is that little slit where the mucus plug is. And when you dilate, the mucus plug comes out. Okay. Now, a short cervix is when the cervix is usually the cervix is about this length. So a short cervix is just shorter, right? And as it shortens, we worry that the cervix will be incompetent. And then what'll happen is that you'll actually dilate and then the baby can be born early. So that's what gets worried. A cerclage, which we have a video on, is a method of keeping the cervix closed until you deliver. And it's basically just a surgical stitch. We take what looks like, honestly, regular thread and a regular needle. It's surgical and it's sterile, but that's what it looks like. And we just sew. There's a different sewing technique, and it just sews it shut. And then right before you deliver, we go in, we take a little pair of scissors and we snip the thread, and then that's it. That's what it is. And that's how you have a cerclage. Now, not everybody gets a cerclage. There's a variety of different reasons why you might want or not want a cerclage. There are risks. Risks can include that we would actually pop the amniotic sac, so the sac of fluid where your baby is. We can actually pop that during a cerclage procedure, and then that can lead to other complications. So some people choose not to have a cerclage. It just depends. Now, if you don't have a cerclage, you might be told to have bed rest. And bed rest comes with its pros and its cons. And I do have a video on bed rest. But what I'm going to tell you is this. What's the best way to get through bed rest? First, to understand what your bed rest actually means. A lot of people think if I'm doing bed rest, that means I don't get up for anything. I don't get up for anything. I get up to go to the bathroom. And that's not necessarily true. We now don't recommend bed rest like we used to because bed rest poses a lot of risks to mom. It poses a risk for pneumonia. It poses a risk for blood clots. It can also pose a risk for other things related to circulation. It can increase your risk of diabetes and hypertension because you're not moving around. There's a lot of bad things that can happen. We need you to be healthy to have a healthy pregnancy. The reason for bed rest, especially when you're having a short cervix, is you don't want this baby's head to be, if you've got this cervix here, when the baby's head pushes on it, eventually it could cause dilation, right? So we don't want a lot of this head sitting on that cervix and possibly dilating it early. But there are ways to modify your bed rest so that it can still maintain a healthy pregnancy for you and prevent preterm labor, which is why the number one trick is to understand what they are asking. So, are you allowed to go to the bathroom? So some people can go to the bathroom. They can take showers. Some women are not allowed to take a shower for the entire time they're on bed rest. That's right. They do sponge baths in their bed. Some people are allowed to poop in a toilet, but they can't pee in a toilet. They have to pee in a bedside commode. Some people can't do either. Some people can cook dinner on their bed rest. They're allowed to get up for short periods of time. So you really actually need to know what your bed rest looks like. Because if you're laying on your couch for 12 hours a day, getting super depressed and super anxious, and you only needed to be laying down, for 30 minutes every hour, well, that's a very different journey, and that can create very different outcomes. Now, the next thing is, depending on how much you have to be in a bed or whatever, you need to get stuff to do. You need to find stuff to do because your brain needs to keep going. We oftentimes hear, and I hear this from clients all the time, I can't wait until I retire. I'm going to sit around and do nothing. Oh my gosh, the human brain never does nothing. It never, ever, ever does nothing. Our brains require stimulation at all times. Even if it's mindfulness practices like meditation, you're still actively doing something with your brain. People watching. Yeah, you may be chilling, but you're still doing something with your brain. So you never do nothing. So if you don't prepare to have something to do, it will cause your mental health to really go downhill fast. So that's actually my next biggest tip is to make sure you have something to do. And then, find out how long this is going to be. At 21 weeks, you may actually only be on bed rest for 6 weeks, and then they may decide to let you come off of bed rest. So it's one of those things that you want to kind of figure that out too. I feel great. No, nothing, just a little nausea between 4:30 and 5 p.m. Yep, it's very good. Oh, lemon. Interesting. Good tip, Nicole. I've never heard of that, but I mean, everybody's got their own tips and tricks for their nausea. So that's good. Lemon. I like it. Okay. I had a question on UTIs, and this is going to get into antibiotics. So here we go. In my urine culture report, there is Enterobacter bacteria. I'm 29 weeks pregnant. What should I do? Okay, what you should do is you should 100% get treated for that. In fact, there's a ton of different bacteria and stuff that can cause urinary tract infections. Enterobacter is actually more rare and can cause more serious issues. So I'm hoping at this point for this person, they have been offered an antibiotic. So let's talk about UTIs and antibiotics. So you have your vagina, and right above your vaginal hole, right above it is a little hole. That's your urethra. And for women, our urethra is really short. So we have our bladder, right? And the urethra comes down. It is tiny. It's like really short. And it's right next to our vagina and our anus. So when we're going to the bathroom and we're wiping, it is very easy for bacteria to get into that little urethra and just go right up into the bladder. Now, your bladder is like a balloon, and this is where the urine is stored. And what happens the reason why we get urinary tract infections is basically because it's dark and warm and moist, and the bacteria can get up there, and then voila, it grows and we've got an infection. Now, a lot of women are able to fight off urinary tract infections because they drink a ton of fluid, right? So they're peeing all the time, and they're just able to also fight it off naturally because they're not immunocompromised. But here comes the pregnant lady. So 1, you're immunocompromised. 2, you've got this baby who sits on top of this bladder and smushes it into weird spaces and like does all this stuff so that when you go to the bathroom, where most people would pee out all the urine that's sitting in there, sometimes as the urine comes out, the bladder will actually shift a little bit and then you leave some left over. And so that leftover can then turn into that UTI. Now, in pregnant women, urinary tract infections are extremely serious. And the reason why is that if it's left untreated, it can actually turn into sepsis. And it does it because from the bladder, we have 2 ureters. Okay. These are tubes that go into the kidneys. Okay. So these ureters are also short and they go into the kidneys, and that bacteria can travel up there into the kidneys. And now you get a kidney infection called pyelonephritis. One of the things kidneys do for us is they filter our blood. And so you have a lot of blood flow going to your kidneys, which is why it's so easy for a kidney infection to turn into a blood infection called sepsis. And the next thing you know, you're very, very sick and we're having to deliver your baby early. So this is why we need to treat your urinary tract infection with antibiotics as soon as it's diagnosed. Now, a lot of people will hear stuff that's like in like you'll hear it like on Facebook and like all the social media or your friends. Oh, you can treat a urinary tract infection with cranberry juice, or you can just drink a lot of fluid. That is a no, guys. That is an absolute no. So cranberry juice can help prevent urinary tract infections. The reason it works is that cranberry acidifies the urine, making the environment more challenging for the bacteria to grow. So it will not cure a urinary tract infection, but it can help prevent. Drinking lots of fluid is probably one of your best bets to trying to prevent a urinary tract infection, because if you drink a lot, then you pee a lot. And so that's one of the ways that we do that. Now, once you have a infection, whether we're talking about like the bacterial vaginosis from before or urinary tract infection, once you've been diagnosed with some kind of infection that needs to be treated with an antibiotic, they're going to give you one and you need to take it all as prescribed. So here's why. That's my cat. Welcome to the live. So you have, imagine the bacteria as like an army, okay? So you have all these lines of bacteria that are just here. Now, I give you the antibiotic and you start taking it. And that antibiotic starts killing off the front lines of that bacteria, right? But all these guys in the back right here, they're watching. They're figuring out how is this antibiotic working? What is it doing? And they're building a wall at the same time. So they're building a defense and they're learning what your strategy is. But in the meantime, this antibiotic starts to make you feel better because it's knocking out bacteria from your system. So after like a day, you feel better and you're pregnant. So you're like, oh, I don't want to give the baby anything. So you stop taking the medicine. And for a couple days, you feel okay. But here's what's happening in the background. In the background, these guys built their wall and called in reinforcements. And about 2 or 3 days later, you feel awful again. And then you're like, oh, I should have taken all that med. So you start again. But this time, it doesn't work because these guys have a wall. They figured out your strategy. So now that antibiotic that I gave you the first time, the one that was more mild, it doesn't work anymore. And now I need to give you something stronger. This is why if you are diagnosed with a bacterial infection and you are advised to take an antibiotic and you choose to take the antibiotic, you need to take it all as prescribed, every single last pill. Otherwise, that is how you get antibacterial resistance. So I don't like to lose good sleep to pee all night. I sleep so good until, yes, that is very true. And the thing is that one of the reasons why pregnant women also tend to get a lot of urinary tract infections and the number one cause of preterm labor, preterm contractions and stuff is actually dehydration. I can't tell you how many times people come in, they're contracting, we give them a bag of fluid in their IV, and then they're done. They're back home because they were dehydrated. And it's because pregnant women do not want to be up all night peeing. So yes, that is very true. Welcome. For those of you who are joining me, I am Dr. Samantha, the maternity mentor. Please feel free to put your questions into the chat like we've been doing. I am answering some of the questions that I've gotten on the videos. And if you stick with me until the end, I will give you a sneak peek at tomorrow's video. So speaking of infections, another common infection are yeast infections. So got a question on my yeast infection video. It says, can I use Turconisol V cream 0.4? I am only 8 weeks and 3 days pregnant, and the doctor prescribed it to me. So this is a great question. So one of the things you guys should know is that in my line of work, I receive specialized training in medicating women who are pregnant and postpartum. Your OBGYNs have also received this same training, your midwives, etc. Now, we utilize resources to help us. Research changes all the time. Information changes all the time. Safety profile changes all the time. And so we all have access to a variety of resources. And one of the resources you guys have access to is your local pharmacist. Pharmacists have specialized training. They're up on the latest information for drugs, and they really, really, really are a good resource to have. One of the guides that I go to is a book that was made by Dr. Thomas Hale. He is a pharmacist, and what he did was he aggregated animal studies and half-life and molecule size and fat solubility and safety profile and all this different stuff related to all these meds. And he created a safety scale for medicating women who are pregnant and medicating women who are breastfeeding. And he's one of the biggest go-to resources when we're determining how to advise women on their medications. Now, yeast infections. Yeast infections are a different type of infection. They also can lead to preterm birth, stillbirth, miscarriage. So it is extremely important to treat them as well. They do not respond to antibiotics. They respond to antifungals. Turconisol is an antifungal. According to the information that I found from Thomas Hales as a source, this is a medication that's very much a risk versus benefit, and they try to avoid unless necessary in the first trimester. So it is highly absorbed into the vagina, which means it's probably going to be absorbed and sent through the placenta. Turconisol has no documented risks for birth defects or such. However, in some animal studies at higher doses than human levels, there was some risk of birth defects, including delayed formation of bones. So for this reason, this would be a medication that you'd want to have a very active risk versus benefits. Why is it that I need to take this medication versus what are my other options for medications? Are there other options for medications? That's very important. Now, many of you might be saying, well, I can go down to the drugstore, the local pharmacy, and pick up a yeast infection treatment off the shelf. Why can't I just use that? You should never assume that any of the medications you see on the shelves of the store are safe for you if you are pregnant. In fact, there's many that are not safe if you're pregnant. So with yeast treatments, they actually mostly tend to be they mostly tend to be safe if you're pregnant. However, some of the different ways that you administer it, your particular pregnancy may not be a good candidate for. For example, some of them have a little suppository that has to be stuck up. A lot of the providers don't want you to use that. They'd rather you use a cream. Some would rather you use an actual oral pill like diflucan, which can be used despite what you might see on the internet. So it's very important that you have a conversation with your healthcare provider. The other thing is, don't just assume that you have a yeast infection because it looks like every yeast infection you've ever had, or don't just assume it's only a yeast infection. If you're having any kind of discharge, and we have a video on vaginal discharge that we can link into the description, but if you're having any kind of discharge, you want to go ahead and let us swab you so we can send that out to a lab and make sure we know what kind of discharge it is. Okay. But that's a really good question. So as far as the trichonicol goes, it can be used when risk versus benefit, benefits outweigh the risks, but I would be having a conversation and asking if there's any other options. Okay. Second trimester bleeding. So I'm 19 weeks pregnant and my doctor is giving me progesterone lubricant. Why do I have pink discharge? My baby and my cervix are okay, but I'm still worried. So progesterone is a hormone that is part of a healthy pregnancy. We need these healthy, when we're pregnant, we need a healthy amount of certain hormones for the pregnancy to sustain itself. Progesterone for the longest time has been used to prevent preterm birth. There's starting to be a lot more coming out that actually is not really effective at preventing preterm birth, but it's still being worked on basically. But they are pulling some products as like the FDA just recently pulled back on one of the progesterone shots because their emergency approval has not bared out to be something that's actually like worthwhile for pregnant women to use. There's just not enough evidence to say that it will prevent a miscarriage. But progesterone is still used just the same. So what I'll tell you is a lot of people get really nervous now because they are starting to hear some of this information. There's nothing to say that progesterone harms a pregnancy. It's just we're not sure that it is actually helping the pregnancy either. But because it's a hormone, it's going to change like the lining and stuff, which is why you can sometimes get a pink tinge, which is usually some kind of bleeding. It can cause the tissue to be a little raw. And also you could just be bleeding. I mean, there's many reasons why we bleed, including placental issues, a subchorionic hemorrhage. So it's hard to say why you're having pink discharge. And it's probably nothing to do with the progesterone lubricant. But you should be asking your healthcare provider to do an ultrasound to see if they can rule out some of the placental issues that could be causing that. So I don't have a great answer for that, but it's probably nothing to do with the progesterone. What can cause difficulty breathing while in the second trimester? I could say a funny thing like everything, but I'll answer. So there's a lot actually. So for starters, the uterus by 20 weeks is about at your belly button, and then it keeps getting bigger and bigger. So it pushes everything up. So it starts to push on your diaphragm, which is this like membrane that allows for like, it separates like your lower abdomen from your lungs and stuff. And so it pushes up on that, which pushes onto the lungs, and that causes it to be harder to breathe. Right now, your lungs are fine. They just, you take shallower breaths, which can make it like a little bit harder. Now, the other thing is, and I actually had this happen recently with a patient, she was starting to have some chest wall discomfort and stuff. And it's actually because she went and got checked out. You should always get checked out. But it's actually because during your pregnancy, a hormone called relaxin starts to increase. And relaxin is actually the hormone that helps to, like, it relaxes all the joints so that your pelvis can actually like soften and widen so that the baby can come down and you can have a vaginal birth, right? So what happens is that because that's relaxing everything, it can relax all the different joint spaces in your chest wall, between your ribs, and that makes everything slightly shift, which can cause you to feel like it's a little bit harder to take a deep breath. Now, some women also have really bad gastrointestinal reflux disorder, GERD, heartburn. That can also cause it. And then finally, it could just be that it's the baby is just like kicking up there. I mean, it's really hard to say without, a little bit more information, but unfortunately it's super duper common. And you could have a big baby, Jade. I will tell you that, like, I could not breathe with my son. I could not breathe. It was horrible. And when he was finally born, he was 23 and a half inches long. He was like huge. And that's why I couldn't breathe. He was huge. He was ginormous. He was like all the way up. And I've had other women say that, like, they do the ultrasounds, everybody says everything's normal, and the baby comes out and it's just, the baby's giant. So it also depends how far along you are in the second trimester, because, at, if you're closer to like the 24-week mark, like 22, 24 weeks, you're getting into third trimester, your baby could be getting really big already. Nicole, can yogurt help bacterial vaginosis along with antibiotics? So oral yogurt, like eating yogurt, yes, it can. You do not want to put yogurt in your vagina. Okay. You can actually do that, women, just so you know, when you're not pregnant, you can actually put yogurt into your vagina to help with your bacterial flora, not when you're pregnant, but yes, you can eat yogurt. You can also do some probiotics. That's also usually pretty good for you. Okay. And I always think everybody should take probiotics when they're taking antibiotics. And Nicole, heart palpitations. So a lot of people have heart palpitations, and I will tell you, in my practice, I'm seeing a lot of just my patients have heart palpitations, and 9 times out of 10, what they need electrolytes. And I'm finding this to be more and more of an epidemic. I think people really just all need to be taking electrolytes every day. The earth is getting warmer, and we're using up more stuff. For pregnant women, a great electrolyte, as long as you do not have diabetes, is actually coconut water. Real coconut water is an excellent form of electrolytes. And a lot of pregnant women will use it, and it can be really good for you. So that might be a good option. My doctor has me avoiding added sugar and bread because my baby's stomach is measuring 2 weeks ahead. Is this safe? Oh, yes, Jade, it is safe to avoid carbs. Please check out my keto diet. Keto is a low carb diet, and I have a video on it. I am a very big proponent of keto. Keto is basically just eating high protein, high healthy fats, and low carbs. And when you're choosing carbs that are much more nutrient dense, and they're much better for you. The ketogenic way of living is really, really, really good for you. It's very healthy, and it can be really, really good for a pregnancy. So bread is basically useless to the human body. We never were meant to eat bread, ever. There's no point to it. Human beings we don't digest that right. And as far as added sugar, absolutely, there's no reason. And if you were really worried about sugar, you could like just add in natural sugars. You could just eat, more fruit and stuff. But I wouldn't recommend you eat a lot of fruit. You don't need it. There's actually carbs in things that we don't think about, like an avocado. Avocados are a great source of a healthy fat, and they're also have carbs. I mean, pretty much everything has carbs. So yes, please check out my keto diet. I am very pro low carb. I think it is the best way ever. And that is absolutely probably part of what's happening. And actually, now that I think about it, it could also be polyhydramnios, which I think I have a video coming out on soon. Polyhydramnios is when your body is producing too much fluid, and this can also cause you to be having trouble breathing. So that's very good. Please check out my keto diet. I love keto. Okay, so on to thyroid. So I got a question on my thyroid video. My TSH is more than 150 and I'm 5 weeks pregnant. Is it good to continue this pregnancy or will it affect my baby? So this is a very interesting question. So I'm going to start with 150 is not a number that I am familiar with. Now, for any of you guys, if you're ever having conversations or doing research, which you really shouldn't look at Professor Google, it is not your friend. But if you are, every lab has their own set of lab values. It's getting more and more standardized so that there's not a lot of confusion, but technically you can have different ranges in different labs. When I hear 150, this is not a measure of TSH that I am familiar with. So I am going to assume this person meant 1.50. That is what I'm going to assume this person meant, because 1.50 is a number that would make sense for TSH. If it is 150, I cannot say anything other than go to a doctor, because that is just way beyond. Normal TSH levels for an adult between the ages of 21 and 99 are generally speaking 0.27 to 4.2. Thus, 150 would be really not normal. Okay. But 1.5 would fall right into the middle of that. Okay. So right into the middle. Now, if it's 1.5, that's totally fine. That's normal. That shouldn't be an issue. Even in the first trimester, it goes from 0.18 to 2.99 approximately. So if your level is 150, at that point, that is so abnormal. That's not something that I could comment on. You need to go to a reproductive endocrinologist. Now, the reason why I have a thyroid video out is because thyroid conditions are extremely common during pregnancy. It's extremely common for women to develop them during and after. And the thyroid is one of the most important things in your body that you have. And it's so essential for how your whole body functions that we really keep on top of it to make sure it's healthy. So if you do have a thyroid condition, you need to get it treated right away, because it can lead to miscarriage if you don't have your thyroid in check. So that's why it's so important. Diabetes or high blood pressure here, just when I lay on my side. It's coconut water. Please, coconut water. It's the best. Hi, Michael Jordan. Long time. I haven't seen you in a while. So your wife had an incompetent cervix at 16 weeks. Oh, and a miscarriage. I'm sorry. And she's pregnant again, and she's worried it may happen again. So what are the chances? Unfortunately, there's no way to say for sure. What we do know is that she's at a higher risk, and that's basically the only thing you can say. What they should be doing is they should be sending her to a maternal fetal medicine physician as soon as possible. Maternal fetal medicine physicians are the high risk doctors. They're the doctors that deal with all sorts of pregnancy complications. And the maternal fetal medicine doctors, they're fantastic, because every time you go in, they do their own ultrasounds and they read their own ultrasound. So right then and there, they will do the ultrasound. They can tell you how long the cervix is, how thick, how effaced she is, all that stuff. They should also be able to start counseling her if she had an incompetent cervix on whether she wants to get a cerclage. The earlier a cerclage is done, sometimes the better the chances. And there's two different forms of a cerclage. However, just so you know, you can have an incompetent cervix with one pregnancy and not have it again. Sometimes incompetent cervixes are caused by infection. So when I talk on my videos about like you need to treat your urinary tract infection, because if you don't, it could lead to preterm birth and miscarriage. What actually happens there is that in the process of not having that infection treated, the uterus usually develops the infection and it becomes irritable, and then the body will the uterus will actually cause dilation of the cervix, and then you miscarry. So it's actually the full process. And so one of the reasons why that happens is your body, usually about before 20 weeks of pregnancy, your body is trying to save you, the mom. So the body can have a sense of a pregnancy that is not going well. Now, that doesn't mean that the baby was not fine. The baby could have been fine, but there could have been an infection that was spreading throughout the body, causing possible sepsis. And so the body was like, nope, we need to stop this or the mom is going to die. And so then the body goes into preterm labor. When you start to have contractions, what happens with the contractions? So uterus, and you got your cervix, right? This is the cervix. The contraction's designed to pull that cervix apart and dilate it. That's what the contractions do. And so that's what happens in preterm labor. And so when we treat the infections, we don't get that uterine irritability that can lead to that. So, Michael Jordan, if your wife's original miscarriage was the result of possibly an infection, even an infection that was undiagnosed, that could explain why the cervix started to dilate. And when we say a shorter cervix, so the cervix, they're supposed to be long, right? But if your body has started dilating it and you don't know, you could have a shorter piece of the cervix left. It was originally like this. Now it's like this, but you wouldn't necessarily know that. And early in the pregnancy, you can't always feel contractions. They often feel like the cramping we were talking about earlier. So there's no way for me to tell you the chances, but what I can tell you, the 100% best chance she has of having a healthy pregnancy is having a maternal fetal medicine physician on board who is regularly seeing her. Number 2, she's taking a prenatal vitamin daily. Number 3, she is drinking plenty of fluids, including electrolytes. And number 4, she's eating as well as she can. I mean, it's hard if you've got nausea and stuff. I hope that helped. Let me know if that didn't, okay? Like if you have any other questions. I've got my last question from the videos that I'm going to answer right now. So if any of you guys have any questions, feel free to put them in. The last question I got was actually on my C-section video. And it said, I'm 4 weeks and 5 days post C-section, and I just felt hard scars like lumps underneath my skin close to my scar. Should I be concerned? So, I have a video actually on C-section, like scars and like incisions and healing that you should check out. I think it's very important. Underneath a C-section, so what happens with a C-section is we cut through many, many layers until we get to the actual uterus to cut the baby out, right? Okay. So as you're coming back through, we start sewing back through different layers of like tissues. So you can have some lumps and bumps underneath that actual healing scar. So you've got to give your body a long time to kind of adjust with that. What would be important to be getting checked out like right away would be if the actual incision isn't approximated. So approximated means that it's close together. This is open, this is a closed together incision. So if the incision is open in any place, if it's oozing, if it's red, if it smells, those are all reasons that you need to go get it checked out. But if it's a little lumpy and bumpy and stuff, no, it still needs a lot more time before you could say either way as to how it's healing. I would give it at least 12 weeks, at least 12 weeks. And really, it also, you need to look at your own healing. Like, are you a person that scars with a lumpy, bumpy scar? If you are, that's what your C-section is probably going to do. And that's what that goes into further. But a little bit of stuff underneath is okay. Now, if you have pain that far out, you do want to get it checked out. And what they can do, just so you guys know, and in like this person with the C-section scar, like even if you're a little nervous, just go ask them. They can do an ultrasound. So they can just ultrasound that C-section scar and just look and see what all those little bumps are. So if you've got like a an abscess, which is like a fluid filled like pocket, that it'll look differently on the ultrasound. So they can see that and then they can determine what's going on. I mean, I've had that before. I've had minor little procedures and had like a little bit of pain like 6 weeks later and said, ultrasound this. Let's just make sure there's nothing going on. And most of the time they're going to say nothing's there. It's just you healing, but it's easy and you can just get it done. So all right, so that's the end of the questions that I have from the videos. I hope this has helped all of you. For those of you guys who have stuck around until the end, we do have another video coming out tomorrow. Tomorrow's video is on stiff necks for babies, otherwise known as torticollis. Torticollis is one of the most common kind of things. Well, one of the most common conditions I see. It's a very common cause of feeding issues for baby once they're born. And this is feeding issues with both the breast and the bottle. So please check that out. For those of you who can, remember, like and subscribe to my channel. Subscribing really helps me out, guys, as a content creator. And then you can hit the notification bell and be notified of cool, exciting videos like torticollis. I'm Dr. Samantha. I'm the maternity mentor. I'm here every Monday at 9 p.m. Eastern Standard Time to answer your questions live. I love doing it, as well as any questions that you have submitted onto the videos. Please check us out on Facebook, Instagram, and Twitter. Please share the channel with your friends and family. We really appreciate all of your support. I'm very passionate about what I do, and I love sharing it with you, and I really hope it helps. Please come back next Monday and see us as we do another one of our Q&As. I appreciate all of your support. Have a great evening. I'm Dr. Samantha, the maternity mentor. Bye for now.